Thank you to the organizers for inviting me, most importantly to my wife, Dr. Ahmad, who's been organizing this as well, and she finally convinced me to come this year. My talk will summarize a non-invasive hemodynamic monitoring paradigm that leverages a mathematical model of the human cardiovascular system. A'udhu billahi minash shaitanir rajim. Bismillahir rahmanir rahim. From the Holy Quran, chapter 50, verse 17. I think this quote manifests what we're really going to talk about for the next 10 minutes. And assuredly we have created man, and we know what his physical self whispers to him, and we are nearer to him than even his jugular vein. So the context of our research in this talk is the global burden of cardiovascular disease, be it heart failure, myocardial infarction, hypertension, stroke, and other peripheral vascular disease. Clearly a major cause of death around the world. It also affects men and women separately. While men may contribute to 1 in 3 deaths over the last few years, in 2013 at least 1 in 4 women succumbed to cardiovascular disease. And unfortunately, in women in particular, it is very insidious in that it has very little antecedent symptoms, and it often comes on without warning, resulting in sudden death. Clearly, early diagnosis is the best weapon we have for treatment, and we reserve medications and surgery as a last resort. So in that context, some of you may recognize what you see here as some of our older, more traditional tools that we use to diagnose cardiovascular disease. So there's the EKG, the electrocardiogram. There are more invasive methods like the pulmonary artery catheter, which we insert into the heart, in addition to an arterial catheter that we put into somebody's artery. All of these are very helpful, but also very invasive and have their own risks and benefits. What you see in the right side is what we are talking about, which is a load sensor that we can place under the mattress of a patient, and it can be the patient in a hospital, it can be a nursing home patient in a nursing home. And it basically gives us what we call the ballistocardiogram. So we're going to talk about what that is and how we use mathematics, which is the universal language of the universe, to assess cardiovascular disease without even touching the patient. So what is ballistocardiography? So I'll call it BCG because it's quite a mouthful. Essentially, think about a center of mass, right? So if you have 2 objects that are of the same mass, the center of mass is right in the middle, as evidenced by this fulcrum. But if one of the masses is bigger than the other, if that changes, that center of mass changes, right? We already know that. So now imagine, as the center of mass changes, if this happens in real time, you now have real-time changes in the center of mass, and the fulcrum has to change in position. So think about this in the context of your body. Your body's center of mass, even though you may be standing or lying completely still, is always changing on a very minuscule, almost imperceptible manner. As your heart pumps blood, the counter motion of the heart's pumping, as well as all the blood that's sent throughout your cardiovascular system, induces tiny counter changes in your center of mass, which you and I cannot sense. But we, through the sensor that we use, can sense these changes and actually extract a considerable amount of information that we never could before non-invasively. So this is an example, and I'm not sure the video will work, but that's okay. What you see is one of our grad students in the lab, and he's lying on what we call a kind of a load sensor or a load bed. Essentially, it's a suspended bed, which in theory is disconnected from any external forces. And what the video would show is, if you look closely down at the bottom, there's a little chalk drawing of a 2-dimensional axis, and there's a laser pointer. And over time, without any imperceptible external forces, you'll see that laser pointer move. And that pointer is moving as a result of the counter motion of the patient's own breathing, as well as their heart pumping. So the question is, can we design a sensor that's sensitive enough to pick these tiny deviations in the center of mass up, and can we extract information from them? Let's see. Oh, it might be working. Let's see what happens. So there is some audio, but again, if you watch carefully, and I know this sounds like looks like a parlor trick, but it's not. There actually is movement that we are not doing ourselves. It's the patient's own body, own breathing and heart rate and blood pressure that are moving the bed, which otherwise is disconnected. So of course, we can design a sensor, and that's what this talk is about. That's the BCG sensor, ballistic cardiography, where we can design a sensor that can pick up these tiny changes not only in respiratory rate, heart rate, and can even extract blood pressure without touching the patient. And what you see is the EKG tracing, and you see what we call the BCG signal underneath. And that signal you're seeing is just one axis, but in fact, the body has 3 dimensions of motion. Most of it is in the axial or lateral, but there is some kind of anterior-posterior movement as well, clearly not as much, because the heart pumps blood throughout your 3-dimensional system. So this entire premise is using a sensor designed to pick this up. Now, what do we do with that data? So we have 3-axis data, and we combine that BCG sensor data into a MATLAB model, which is designed to reconcile that data with what we call an electrophysiologic model of the cardiovascular system. So if you think of the heart being replaced by a battery or a volt source, and the current being the blood, and then the blood pressure being resistance and capacitance, if you design a system and an algorithm that encompasses the entire body's cardiovascular system as an electrical circuit model, the MATLAB system then reconciles that BCG signal into that model and gives us what you see here. It can give you not just heart rate and blood pressure, but we believe, and we've done this theoretically in the lab, that if we combine it with an audiographic signal of the heart pumping as well as the EKG, and we combine those 3 signals, we can regenerate what I, in the kind of critical care realm, call the holy grail of hemodynamic monitoring, which is what you see on the lower left corner, which is a pressure volume loop of the heart. So as the heart pumps, right, opens and closes and the stroke volume ejects, we can extract how hard the heart is working with cardiac power output. We can also extract very discrete thermodynamic principles, which is how efficient the heart is. As we get older, our heart gets more inefficient. As we are critically injured or are septic or have blunt cardiac injury in the world of trauma, our heart gets less efficient. So if we are going to treat that heart, it's best to know exactly what the thermodynamic efficiency is before we just throw blind medications at it, because we can change the blood pressure, but unless you fix the thermodynamic efficiency of the heart, you're going to lose the heart and you're going to lose the patient. So, of course, from theory to practice, one of the first uses of our sensor in the real world, was done at the University of Missouri with our engineers using a prototype BCG sensor. We compared healthy subjects, much like one of our grad students here, this is Muhammad, who's actually received his PhD just last year, compared it to real ICU patients, where we basically evaluated the 3-axis BCG signal and compared it to their EKG tracing. And we wanted to see if we had accuracy equivalent to the EKG tracing. So this is, again, without going into the details of how the math was done, we effectively compared the 2 signals. We regenerated our own BCG signal and the EKG signal. And it stands to reason that if your EKG signal tells the heart to pump, there's a slight millisecond delay in the heart actually pumping. It takes a little bit of time for the heart to fill, pump, and eject for you to register a signal that something's moving and register a heart rate and register a blood pressure. That delay, actually, we found to be a very discrete variable that we found to be significantly different in people that are ill and people that have heart disease. And we've actually found that difference, which we call the TEB, which is the time interval between the EKG and the BCG, to be different between men and women, even healthy men and women. So we think we have found a non-invasive method, a metric or a variable that not only tells you if you're healthy, but if you're male or female, and whether you have some pathological heart disease that is manifesting in delay between your EKG and your heart pumping itself. So this is just a quick snapshot of that TEB interval across several sessions and several patients. And you look and you see the p-values are not significant at all. But that's the point, right? We don't want them to be significantly different. What this tells you is that across several sessions, we have a repeatable and reliable TEB data from our BCG signal that is not different, that we can repeat this data and we can actually use it across several patients to gather very discrete information about somebody's cardiovascular health. So I'll just close with a picture of what our latest generation sensor looks like. This essentially is a box that looks like about the size of a small child's shoebox. It literally sits on the back of the mattress. If you think on the lower right corner, there's the mattress. That's the head of the mattress. And so the patient would never see it. It sits on the back, and it's sensitive enough to record that BCG signal with the patient who's intubated on the ventilator, sedated, and not moving, regardless of what lines and tubes and drugs are being infused, and generate that same signal with a high degree of accuracy. We're actually using this now in an ongoing study where we're comparing it again to our arterial waveform, comparing heart rate and blood pressure, and eventually combining it with an EKG signal to generate what I call that holy grail, which is the PV loop. So again, I glossed over a lot of things. I didn't want to kind of talk too much about some of the mathematical background, but this is a perfect example of how we took an engineering principle, created a sensor, and deployed it in real time in real patients. And I'm hoping that with more data, we'll get even more kind of experience and hopefully get some funding to do some more fun stuff as we like to do. This is just an example of some of the things that we've done and shown around the country. Some of the work includes the gender differences that I was talking about. And I'm hoping, especially in light of some of the early plenary session we had this morning, that something like this can be deployed in what we in the trauma world call austere environments, where instead of having a complex hemodynamic system, you have something that literally fits in a shoebox, can be plugged into a power source, and give you information that before you needed some very invasive lines to do. So again, thank you for this opportunity. I couldn't have done this without the innumerable number of people working in the lab, both at the University of Missouri, University of Maine, even some researchers in Italy. Foresight is a company that makes the sensor, which is actually licensed out of work done from the University of Missouri. So again, Jazakallah, and thank you for the opportunity.